We did something a little funky with the title, so I'm sure everyone can translate. Early psychosis intervention for Muslim patients. I just want to start by saying a huge, huge thank you, Jazakallah khair, to the conference organizers for setting up this amazing day. And then also, I want to acknowledge how much of a privilege it is to be speaking alongside Brother Yusuf, and he'll share more about his brother's story. But if there's anyone to dedicate this talk to, it is him, and it is such a loss for our community. So our goals for today are identifying the manifestations of psychosis. Some of the more common ones you may be familiar with. There may be parts that are less well known. Understanding the intersections of religion and psychosis, particularly within the Muslim context. Develop an awareness of the disparities in access to care in Canada, and then developing treatment approaches for working with patients with psychosis. So I always like to ground our talks in a case presentation. So this is not identifying any one particular patient, but if we just go to the next slide. Are we still able to use the slides? Yeah. Okay. So background of this individual, and again, this is amalgamated, so several patients that I see, I've used their details just to make sure everyone stays anonymous. So imagine a 21-year-old man, he's of Indian origin, identifies as Muslim, engaged in the local mosque community since childhood, and had performed academically well through middle school and early high school. And then his family starts to notice in grade 11 that the grades are dropping significantly. There are changes in behavior and functioning. So socially, he's becoming withdrawn, becoming quite isolative, not seeing his friends. He's not attending the masjid anymore. He's decided not to return to school in grade 12. Parents are saying that they smell cannabis, but the patient himself is denying that he is using this, and he is observed to be speaking to himself or laughing at times when alone. How do we define psychosis? Psychosis is defined as a collection of symptoms that affect the mind, where there has been some loss of contact with reality. So during an episode of psychosis, a person's thoughts and perceptions are disrupted, and they may have difficulty recognizing what is real or not. Um, there are categories of symptoms. The positive symptoms of psychosis, they consist of hallucinations, which can be of any of the senses. We can have delusions, where people have fixed false beliefs about a particular issue. There can be disorganization in thoughts and behaviors, and then catatonia, which can be a very severe manifestation, a neuropsychiatric syndrome, of which psychosis can be one cause. The less well-known aspects of psychotic disorders are what we call negative symptoms of primary psychotic disorders. And in this, people can present with reduced emotional expression. So their facial expressions, the way that they speak may seem flat or less emotionally expressive. Avolition, which is lack of initiation of activity. And I note here that it can sometimes be mistaken for laziness. It's not laziness, it's part of the manifestations of some of these disorders. Social withdrawal, and then cognitive impairment as well, usually deficits in executive functioning, multitask organization, and planning. So I wanted to share some demographic information. We know that in a lifetime, 4% of Canadians will experience a psychotic episode. 1% of people have a diagnosis in Canada of schizophrenia. 56% of those diagnosed with schizophrenia are men. And then the age of onset is in the late teens, up to the early 30s. And for men, it presents earlier, and women have a later age of onset typically. We know that the suicide risk is quite high. 5% of individuals with schizophrenia will die by suicide. And if you look at all-cause mortality, so due to medical issues as well as suicide, we can have up to 28 years of life loss for individuals with these disorders. So the question comes up, what's religion got to do with it? Which is a very core question that we're addressing throughout this conference. And when it comes specifically to psychosis, I think the answer is a lot. First of all, it shapes people's understanding of psychosis. So not only patients, but their families as well. And globally, we see that many people actually seek help from spiritual leaders first before coming into contact with the healthcare system, because often these disorders are conceptualized as stemming, or the explanation for it can be spiritual or religious in nature. Then we can have religious content to people's experiences. So I have a patient, for example, with schizophrenia during times when they are unwell, can have very significant delusions that are rooted in their beliefs about Islam. But when they are not actively in a psychotic episodes, they won't hold those same delusions. Then we know that service engagement can be affected as well. So how much people actually come into contact with treatment teams, and this leads into treatment adherence as well, where people's adherence to medications or the treatment that we suggest can be impacted by their religious beliefs or the other people that they're seeking out support from. And then suicide risk is fairly complex. So for the general population, suicide is protective, and there is religion is protective against suicide, and we have evidence to show that this applies within psychotic disorders as well. However, certain patients, for example, if their delusions are appearing as a manifestation, for example, they might believe that God hates them, or they may have pathological guilt as part of their illness, that can elevate their suicide risk. So this needs to be explored with nuance. So I wanted to share a very brief historical perspective about how psychotic disorders were treated in traditional Muslim societies. And I think the Islamic Golden Age between the 8th and 15th century give us very interesting perspectives of how understandings of psychosis were developed. As we have heard at this conference, that this was a time of remarkable advances in the sciences, the humanities, and as part of that, there was medical innovation as well. And we see the emergence of what we now consider a biological, psychological, and social model. Biological, psychological, social, and spiritual model of understanding illness, and that includes physical illness and mental illness, as well as treatment. And so the Maristans, which were healing centers during this time period, did include treatment for people with mental illness, right? And that included psychotic disorders as well. When you contrast this with what was happening in Europe at the time, the dominant belief at that time within Europe was that these were psychotic disorders were supernatural in nature, and that the primary treatment offered for that were things along the lines of exorcisms or dealing with possession. And so they were missing this other medical, psychosocial kind of piece to it that we were seeing implemented in the Maristans at this time. And so even when researchers have looked at the kinds of treatments that were implemented at these healing centers, there can be a combination of opium. So we can think about that as the biological treatment at that time. Counseling, rest, and music therapies were all part of the comprehensive treatment plan. When we look currently, I really thought this was an amazing study done by researchers looking at Muslim communities in North America and how they understand mental illness in general, and this includes psychosis as well. And there was a diversity of conceptualizations in terms of how Muslim communities explain mental illness. And a large proportion of them did actually believe this was a medical illness, like and biological condition requiring psychiatric treatment similar to other medical conditions. Other people saw it as a spiritual test from God, a trial. There were people who saw this as jinn possession as well. But the really interesting part of the study was that a lot of people held multiple beliefs, multiple explanatory models. And I think one thing that I see in the Western context of dealing with these disorders is that within the Western framework, we think that people are holding singular beliefs, and that if they hold spiritual religious beliefs about something, that they're then they don't see it as a medical issue or a psychiatric issue. And I think what this study really was showing, that people are actually reporting nuance and multiple different frameworks by which they are understanding the same set of symptoms. I work at St. Joseph's Hospital in a early psychosis intervention team, and this particular concept is very important when it comes to psychotic disorders. So there's a concept called duration of untreated psychosis, and that has really revolutionized our approach to people who suffer from psychosis. And research consistently demonstrates that the shorter the duration of untreated psychosis, the better the outcomes. And this applies to higher remission rates, reduced chances of relapse, and better quality of life overall. So this is a really, really critical concept, duration of untreated psychosis, which should encourage all clinicians to get patients connected to the appropriate services as early as possible. So, for example, in Ontario, EPI teams, early psychosis intervention teams, have their own special funding to try and shorten the wait times people are experiencing, because we know that will reduce to decreased duration of untreated psychosis. We also know that there are significant disparities in access to care. And so in Ontario, there was a study done looking at how people with psychotic disorders presented to emergency departments. And in this study, Chinese and South Asian Ontarians were more likely to present to emergency departments with more severe symptoms of psychosis, so higher rates of involuntary admission and aggression. And so the researchers doing this study hypothesized the reason we're seeing that is because these communities are presenting later, and therefore the symptoms have had longer to worsen and become more severe at time of presentation. We also know from Montreal data, for example, that Black Canadians face disproportionately higher rates of being brought to hospital by police. And that is the first way that they would be accessing mental health care for their psychotic symptoms, which in my mind is absolutely unacceptable, and that this is something that we as a community need to address. And so we also know that within the justice system, and that I use quotation around the justice system, but that there can be experiences of police brutality, which disproportionately affect people of color, Black and Indigenous Canadians as well. And we'll hear a bit more about this from Brother Yusuf as well. So what does it mean for us when we're coming into contact with patients and their families who are experiencing psychosis? And so the first principle that I really encourage people to start with, clinicians to start with, is prioritizing engagement. As you saw from the data around duration of untreated psychosis and access to care, we're working with a vulnerable population who have good reasons to mistrust the mental health system. And so from start to finish, we as clinicians need to demonstrate that that we are engaged with this person, that we are listening, that we are respecting their beliefs and perspectives, and their thoughts about the treatment itself. The second is to make sure that we're assessing the positive symptoms, not just the hallucinations and delusions, although those are very, very important, but making sure then we're also exploring disorganization of thought and behavior as well, and looking for the negative symptoms. So before these psychotic symptoms emerged, what were you noticing in the year leading up? Was this person starting to become more withdrawn, more disengaged? Did you notice changes in how they were communicating, and what their quality of life was starting to look like? And then making sure that you're conducting very thorough safety screening, particularly around suicide, as we saw the rates are quite high. And so you want to be making sure this is addressed in your assessment. I want to remind everyone that psychosis has a broad differential. Similar to a fever, psychosis in itself is a symptom, and you still need to figure out what the underlying disorder or illness is that is causing the symptoms of psychosis. And so there are, and in the interest of time, I will go to the next slide, but for your reference, here are some possible explanations for why people might be experiencing psychosis. I think here, in any mental disorder, the biological, psychological, spiritual, and social model is highly important, but we really see that illustrated in the treatments that have the best evidence for people experiencing psychosis. As I talked about, early psychosis intervention teams are multidisciplinary teams that include psychiatrists, social workers, occupational therapists, peer support workers, recognizing that medications are going to be a part of this treatment, but they're not the full treatment. And I'll go over some of the specifics of the treatments as well. So from a pharmacological treatment perspective, antipsychotics are the mainstay of treatment, and I have seen them be quite transformative for people. Psychosis is a time of high distress for the individual themselves, first and foremost, but for their families. And antipsychotics work in reducing symptom severity, particularly the hallucinations, delusions, less effective at addressing the negative symptoms, unfortunately. Any antipsychotic, first, second, or third generation, can be considered. And again, as we've heard in previous talks, you try to work with the patient's preference and the side effect profile of each medication. The one antipsychotic that does demonstrate superior efficacy compared to all other antipsychotics is clozapine, right? And so that is the most effective antipsychotic we have. Unfortunately, it does come with a significant side effect burden, and therefore we reserve it for people who have treatment-resistant symptoms. And then we have long-acting injectables, which can be very useful when adherence can be an issue. A lot of clinicians ask me about the idea of how long people should be treated for. The Canadian guidelines recommend that after a first episode of psychosis has resolved and stability has been reached, then to continue treatment for at least 18 months. Now, the risk of relapse without medications during this period is very high. Rates of up to 80% of people will relapse if they're not treated with antipsychotics. And then if someone has had multiple episodes, then the recommendation is at least 5 years or long-term treatment with antipsychotic medications. The way I frame this discussion is that, yes, medications have risks, and it's really important to name them and be transparent and to talk through them. And untreated illness has very significant risks as well that we also need to name and discuss and talk about. And then psychosocial interventions are very important. So the Canadian Schizophrenia Guidelines, for example, really highlight family intervention as being an evidence-based psychosocial treatment for schizophrenia. Supported education and employment, so focusing on how we can enhance recovery, help people reach their goals. And then cognitive behavior therapy for psychosis can play a role as well. Addressing substance use is very, very important as well. So we know cannabis is a risk factor for psychosis, and we know that it can lead to the precipitation of psychosis in someone who may not have other risk factors. And for individuals who we predict would have otherwise developed schizophrenia or a primary psychotic disorder, cannabis can hasten the onset of psychotic symptoms as well. And I highlight here that building trust is really important because this is a stigmatized and taboo topic in many communities. And so it needs to be approached with openness and non-judgmentalness. And so consolidating it all together, when I work with Muslim patients and their families, I try to hold on to certain principles like honoring people's explanatory models. We heard this morning that it's not sort of a pat on the head and say, yes, yes, nice, you believe that, but actually this is what we're going to do and how we're going to understand this. It's to really try to build a collaborative understanding with the patient about what's going on, distinguishing beliefs from symptoms. So, for example, we heard the belief in jinn is not psychotic, right? And so many people might misinterpret that, and that can lead to significant harm as well. The idea of respecting parallel treatment, so if people are accessing your help, but also accessing spiritual or religious resources and support, to respect that. And then there have been occasions where I have spoken with imams and chaplains about collaborating on people's treatment plans as well. I have some references here and I'll wrap up, and I look forward to hearing Brother Yusuf's talk. Thank you.
Can you hear me? ربي اشرح صدري ويسر لي أمري واقلة دين من لساني يفقهوا قولي. Respected brothers and sisters in faith and respected brothers and sisters in humanity, I greet you with the greetings of peace. Peace that Sulaiman Allah yarhamu did not have. Before we start the video, I just want to thank Dr. Arfin Malik, Ibrahim Mohammed, and the entire team here for having the courage and the dedication for continuing to have these conversations in this conference, because it is much needed. It's not just a conversation. We're talking life and death. And I'm honored to share the stage with my dear sister, Dr. Zainab Furqan. And I thank all of you. When you give your time, time is very precious in our life. So I'm so grateful for all of you to share your entire day here, and I'm honored to come and talk to you about Sulaiman's story. I'm gonna, and I'm not intending to trigger anybody, but what you're about to watch, it's a 2-minute video. It is very difficult to watch, but it's important that you watch. And a lot of things that Dr. Furqan said is things that Solomon didn't have when he was alive. He didn't have those kinds of experience. It would have been good to have someone to deal with like Dr. Furqan, but unfortunately he didn't. Allah subhanahu wa ta'ala knows it was qadr Allah. But what you're going to see is an interaction with the only person that probably treated Sulaiman, Allah yarhamu, well in this institution. And I thought that we start with this. And again, I wanted to give you, caution you. This is going to be very hard to watch. I'm also going to try to not watch it. So please play the video. It's about 2 minutes. It's interaction. And this is Solomon and what you can see what's happening to him. Bismillah.
Sort of left trying to figure it out.
Yep, there we go. Solomon, how are you? Trust? Who are you looking to trust?
So on the Sunday the 11th, I arrived in the institution for my scheduled shift. As soon as I seen his living condition and I observed him for a moment or two, I had a sinking feeling in my stomach. I encountered a staff that were frustrated, that were scared. They see what's happening. The officers that I worked with that day, none of them were angry at Solomon. They were angry and frustrated at the lack of response, the lack of direction. You know what? They were concerned because he had been flooding his cell, so they shut his water off. And they said, Clark, he hasn't had water on. What do you mean his water's off? I directed one of my officers. I want you to film my entire interaction with Faqiri.
Trust? Who are you looking to trust? Pardon me? Trust who? Yes, who, Solomon? You don't trust them? I trust all the time.
I'm assessing his ability to listen to me, trust me, and not act out in a violent way. And I looked in his eyes. Behind the mental illness, you could see the fear.
A video of the cell, please. Can you see the condition of the cell? The stench of feces, urine, and vomit by the appearance of it. Acting irrationally. It's not responding. I'm going to try to get him out and get him cleaned up. Solomon, come here and speak to me, please. Who is it you don't trust, lad? Okay, so give me your hand. That works. Good job. Thank you. You're doing well. I trust you. I'm not going to hurt you, okay? So I need you to walk out when the door opens for me. Step out.
I've got 120 things racing through my mind right now. There's no set procedure for this. I'm dealing with that emotion of fear. It's a fear of how I'm going to handle this and protect everybody involved. I want you to get clean. Come on, let's get some soap, get some water on you. Come on, I'm up in the shower.
This was not in some faraway land. Lindsay, Ontario, it's about 45, 50 minutes from Toronto. Took my family 11 years to take care of Sulaiman, Allah yarham. The system 11 days for him to be killed. Ironically, my family had privilege, able body, speak the language, take off time work to go take care of him. Now imagine there's a Sulaiman that didn't have any of that, but we still lost him. We went to this institution for 4 times in those 11 days. My parents, myself. And today, when I first spoke in this conference, when Dr. Malik invited me, was the second year, was the year after Sully's death. We're in the 9th year. Next week will be the 9-year anniversary of his death. This officer that you saw, he said, I didn't have the tools. Well, he's right. He didn't have the tools, but he was a decent man. In that institution, for 1,100 individuals in that institution, which a significant number suffer from mental health challenges, one psychiatrist. So you had one, like, you would have like a one Dr. Arfin Malik or Dr. Zainab Furqan, like one for 1,100 individuals, and one general physician. Now, in the week that Suleiman was there for 11 days, that psychiatrist was on vacation. So you saw the GP. The JP, in a very smug, arrogant, and again, this is going to be a very difficult conversation, but it's important for us to have this conversation. There's a high-profile coroner's inquest 2 years ago that deemed Salman's death a homicide. And I'm not going to talk about the violent death. I want to talk about, going a bit more from Dr. Furqan's part about psychosis and support. No, I want to touch on that, but I want to just talk about the GP who did see Sully, wrote in his notes, and in the coroner's inquest, it came out, he even after seeing Suleiman with his feces, and I'm being vulnerable in front of you, ladies and gentlemen, but I'm being vulnerable because you have that power to help someone like Suleiman. You have that power. You do. The JP doubled down in the coroner's inquest saying he made that decision not to send Salman to the hospital. And in the coroner's inquest, he said, I would do the same. I'm not a medical professional, but what kind of preposterous statement is that? You could see the gap that he said, I'm not going to send him to the hospital because, him just having his feces, it's not a big deal. I mean, when you put it in perspective, you're baffled by that gap, right? And so 11 days he's there, and there's a lot about this case that you can go read. There's this documentary, there's a TVO podcast I've written publicly in the Globe and Mail. You could see some of the work that my family, through my mother's leadership, have done all these years. But why am I coming here and crying my guts out in front of you and wanted to show that video? Because that gap between the mental health professionals, right? The justice system, when Dr. Furqan said like this, I believe that as well, is that when people suffering from mental health challenges interact with the justice system, they'll never lose that interaction again. They're going to pay the price sometimes with that interaction because they will always be inside that system. Now, topped off on the fact that when there's a gap, for example, between the mental health care system and the justice system, who pays the price in the end? That individual who's suffering. But why should they pay the price? They don't have the choice to suffer from schizophrenia, schizoaffective disorder, bipolar. It's not there. The onus is on the state and on the institutions to help these kinds of people. But in the end, these people suffer the most. But what makes Solomon's story unique is that what you see in this video, I wish I could say it's unique. What you see us fighting for 9 years is unique. You have a family, may Allah bless my mother, who keep pushing to keep fighting for people that are alive. So it's unique in that the system forces you to be the advocate. Now, if you don't have somebody advocating for you, you're more likely to suffer. That's the tragedy here. But why do people have to advocate? What if somebody doesn't have the means? What if somebody can't take a day off work? What if you're a single mom? What if you're a newcomer? What if you don't speak English or French, or there's a cultural competency? You are forced to advocate. So there's a direct correlation that when you advocate, when the families advocate, they're more likely to take care of their loved ones. I'm not even talking about running into a good doctor. Now that's another story, and that's very important. So what I want all of you, ladies and gentlemen, from taking out of this talk, one of the most important thing is that you have that ability to change someone like Suleiman's life. You do. That ability stays within your parameter, whether it's working closely with their families, or whether whatever whether giving them a certain plan, healthcare plan or certain support. I help every week. I have families reaching out to me. I'm not a medical professional, but I help other families. That's the irony now. The irony is my family, we came to Canada as refugees originally from Afghanistan, but the difference is that my mom, through her love, through her faith, actually, was able to like treat Suleiman, Allah yarhamu, in a way that followed the prophetic message, right? And even when he was diagnosed, the first thing that my mom, a couple weeks, and earlier in the presentation when Dr. Furqan talked about some of her, like some similar, some patients, Solomon's like trajectory almost like that, very similar. But so he was the golden boy. He taught my mom how to read the Quran, how to read Arabic. But all of a sudden he was in Waterloo. He got into a car accident, and my family's golden boy. He was younger than me, but the golden boy, everything just came crashing down. And in my culture, one of the many cultures, within the Afghan Farsi speaking community, we still have a lot of stigma, and it's done in different levels within our Muslim community. But what did my mom do? A couple of weeks before he's diagnosed, she took my father and all of us in the room and said, "You're going to accept my son for who he is." Alhamdulillah. He was diagnosed when he was 19. They killed him when he was 30. So she ended up, like, in many ways addressing that stigmatization, but and that changed everything for Suleiman. But the reason I'm sharing all this is that when we say the mistrust, when Dr. Furqan said the mistrust and the mental health care system, there is. And a lot of people who suffer in these systems, especially folks that are racialized, they have more reason to, because the system is already overwhelming for any Canadian. But now when you add other cleavages of linguistic, ethnic, religious parameters, you have that even more difficulty. Most Canadians that are born and raised in this country have a difficult time navigating through this. So what about someone who, doesn't even have, doesn't come from this field? They will even struggle more. And so the reason this conference, and the thing that I want you to take at least out of my talk, out of what I'm about to say, is that you as individual practitioners, whether it's psychiatrists, general physicians, nurses, mental health nurses, you have the ability to really help people, someone like Suleiman. That ability stays within your parameter, whether, like I said, helping them in multiple facets and not operate from a jaded perspective. I'm not trying to generalize, and I know it's not easy, but this is why his story is so important, because this is a national story from the perspective that there's so many people like him that died like this. Abdurrahman Hassan, Abdurrahman Abdi, Pierre Corlian, Justin Saint-Amour, Cass Geddes, Ashley Smith. I can go on. And if I was hazard to guess here, very well-informed, educated people, you're most likely not to know any of those names. It's not your fault, because the system that we have, whether it's the justice system or the correctional system, operates in an opaque way where there's an unknown. I'm not saying for you to resolve that. That's not the part of this discussion today. But the part of the discussion as mental health practitioners is for you folks that when people like Soli cross your path, you have that ability in many ways to support them beyond just giving the medication, of giving families their plans. And I think that's what's important when I'm about to say. Because I humbly say this, and I mean this with the utmost respect, because I'm not here to criticize anybody. When I look at his face, I always say, Alhamdulillah, Alhamdulillah, Alhamdulillah. I'm very grateful. I'm grateful. I'm speaking in front of you today. His name is still talking about Alhamdulillah. I never said why. Alhamdulillah. And when I visit his grave, I always say to him, I'm going to use your story to make sure that when there's someone like you, that your name and your story will help them. This is my family's humble way of giving sadaqah back. Our contribution is that, and that was Solomon's time. We accept it. But I think when we look at his story, we should be motivated on how it can help people like him. We should also have that difficult conversation that these systems are not a one-size-fits-all. These systems have to be approached, have to be used in a way that when you're dealing with patients, there has to be multiple cleavages that as practitioners you use, whether it's linguistically, culturally, ethnic, understanding certain, certain notions of all those cleavages, that has to be a multifaceted approach. And I think what I've learned in all these years, and almost a decade since his death, next week, as I said, will be 9 years, is that there's a need to shift those conversations. And there's a need to have things where, like Dr. Furqan said, that, we need to work with, whether it's an imam, whether it's a rabbi or a priest, because what that will do, that would give the psychiatrist and the mental health professional a certain framework on how to provide that support. I know all mental health professionals, they're well-meaning, but you as well, my dear brothers and sisters in faith and in humanity, you as well have a gap. That's not your fault, that's not on you. But to address those gaps, one, it starts with important conversations like this, and then you take the courage and the leadership to get other facets involved. When you look at, and all the names I just mentioned to you, those people came from different cultural backgrounds, socioeconomic backgrounds, rural backgrounds, linguistic backgrounds. But the difference between them and Sully is that through my mom's leadership, we decided to fight. And it's a price that we're willing to pay. And so I hope today, whatever you heard from me, is that I hope this motivates you to bring that change, inshallah. And that all of you in your own worldview, in your own experiences and journey, have that ability. And I have no doubt that the Suleimans of tomorrow will one day, inshallah, be treated as insan, as human beings with their own life and stories, with their own abilities. When I see my mom reading Arabic and reading the Quran, she always mentions him. That was his gift to his mom, And again, educated guy. He learned Arabic when he had schizophrenia, right? These are capable people. They don't want to for you to feel sorry for them. That's a part of them. So I think, for me, in many ways, Solomon's story is an opportunity. Solomon's story serves us a path forward to help the most vulnerable. Solomon's story gives us a limelight on what happens in these systems. He was there for 11 days. And I don't want to break everyone's heart. So we had like a plan in those 11 days, and I want to share this with you just to give you context. In those 11 days, so my dad and mom, the plan for them was, okay, you go to the jail. I would take care of dealing with the justice system. Ironically, I'm going to share this again. The day that Solomon was murdered, I was an advisor to the Deputy Attorney General. So I'm a civil servant by profession. This is just to give you background. I'm not here to speak on their behalf. I'm just telling you, I already knew for me, the day that he's murdered, I already know the justice system. You see, about privilege. And the day that, we found out that he's dead on the Thursday at 9:00, my mom's pacing in the living room. My dad's in the other room talking to the police officers. What do? After I console them, I don't call a friend that Sully's dead. After I call my two brothers to come home, I call one of my good friends who's a lawyer. Why? Because I knew time was running out. And for me, when you have these systems, unfortunately, what happens, they double down, in the sense that, when I mean double down, no one has nefarious intentions, no. But then when somebody's dead, they follow process. But that process, you end up paying that price. So all that to say that, mental health, it's medically complex. And I'm going to let you folks talk about that. But it's not just the medical system that interacts with it. There's the justice system, the educational system, but the buck stops with you, and the buck starts with you. I pray that all of you have the best of health and the best of success. I pray that this conference continues to expand. May Allah bless Dr. Malik and our entire team. And I thank Dr. Furqan for having speaking on very courageous things in that conversation. And the story will continue. And whether it's in my lifetime or not, this system will change, inshallah. Wassalamu alaikum wa rahmatullahi wa barakatuh.